afternoon. I'll be talking today about the functional GI disorders, and then I'll talk a bit about what we are doing in Jordan. So, functional GI disorders defined as a combination of disorders, age-dependent, chronic, or recurrent gastrointestinal symptoms not otherwise explained by structural or biochemical abnormalities. The term functional emphasizes that many of the symptoms may accompany normal development, like the infant regurgitation, which the children will outgrow it with time. The other thing is maybe a response to otherwise normal internal or external cues. For example, the development of constipation following a painful stooling. The etiology of this, despite the availability of isolated findings and hypotheses of most of FGIDs, still we don't know the real cause for that. But I'll walk you through some of the theories trying to explain what's going on and why those patients are developing FGIDs. So psychological disturbance, it's a well-known association between recurrent abdominal pain and exposure to stressful events. Stress enhances the visceral perception, and anxiety and depression more frequently seen in FGID children compared to healthy individuals. The visceral hypersensitivity, we have evidence also from the literature that patients with functional abdominal pain or even IBS, they have a lower sensory threshold for gastric or rectal balloon distension compared to healthy controls. The FAB ones, they have more with the gastric distension, while the patients with IBS have more visceral sensitivity with the rectal distension. Gastrointestinal motility abnormalities, delayed gastric emptying and impaired enteral motility was found in children with both functional abdominal pain, IBS, or even functional dyspepsia. This is a picture for the EGG, which is the electrogastrogram, and it's found also that they have abnormalities, either tachygastria or bradygastria. Early life events might lead to development of visceral hyperalgesia and abdominal pain in children. For example, patients who are having cow milk protein allergy, having surgery early on in their life, or even development of Henrich's line purpura. Inflammation of intestinal mucosa. Still, patients with functional dyspepsia and IBS, they have minimal inflammation of the intestinal mucosa. And there is a new bulk of literature about the role of eosinophilic infiltration. We hear Dr. Salman in the morning talking about eosinophilic esophagitis. But still, those patients with functional GI disorders, they have an increased number of eosinophilic infiltrates, mainly in their stomach. Mast cell dysfunction and serotonin. Children with IBS have an increased availability of 5-HT in their rectal mucosa, and the 5-HT interacts with peripheral nerves in the submucosa and contributes to the development of abdominal pain through heightening the visceral hypersensitivity and stimulating the pain pathways. And just to mention that 95% of the serotonin in the body is in the gut. The human microbiome dysbiosis demonstrated in functional GI disorder patients. There is the proteobacteria and firmicutes are much more abundant compared to bacteroids in patients with IBS. And there is the theory that this will alter the visceral perception, the gut motility, intestinal gas production, and the gut permeability of those patients with the metabolites of those bacteria. Again, the genetic and environmental factors. TNF-SF15 polymorphism has been linked to the development of both constipation predominant, diarrhea predominant, and post-infectious IBS. And monozygotic twins concordance rate is around 17% compared to dizygotic, which giving some credit to the genetic background in those patients, although parental history of IBS was a stronger predictor of IBS in those patients. Post-infectious causes, I don't know if you are familiar with the Walkerton in Ontario. It was a tragic event when the sewage system contaminated the water supply. The for the small town, Walkerton. And after that incident, almost 1,000 people there developed hemorrhagic type of diarrhea. And after follow-up, and a lot of them developed HUS even, hemolytic uremic syndrome. And with follow-up, a lot of those patients developed IBS post the infection. And this is also documented in children. So regarding the diagnosis is somehow difficult because physicians lack of understanding or appreciation of the illness, and at the same time, there is no reliable biologic markers specific diagnostic tests to tackle those diagnoses. How to approach those disorders? Again, it's the principles of medicine. Thorough history, comprehensive examination, and limited workup according to the symptoms that are present in those patients. Historically, the early definitions of functional GI disorders were put by Apley, who is an English pediatrician. In 1958, he introduced the term recurrent abdominal pain of childhood. He was describing kids with recurrent symptoms of abdominal pain without any obvious cause, and he was relating this to psychological causes. The definition by Apley survived almost 4 decades with some mild modification until the pediatric working team met in Rome in 1997 to put the definition and trying to put a classification for the functional GI disorders. 2 years later, in 1999, the Rome criteria, or Rome 2 criteria, was published. In 2006, another revision for the criteria was produced, which is the Rome 3 criteria. And last month, just, Rome 4 criteria was published by the same group. So the Rome criteria are symptom-based. It's not an organ-related. Symptom characteristics, if you are talking about abdominal pain, they cite if there is any associated symptoms, impairment of daily activities, and if there is alarming symptoms or not. So this is the classification from the Rome 4 criteria, which divide those illnesses into 3 major categories: the functional nausea and vomiting disorders, and the functional abdominal pain disorders. The last one is the functional defecation disorders. I'll try to walk you through them. I will not go through the criteria, but I will mention just the changes introduced through the Rome 4 criteria. So functional abdominal pain disorders, the old name was the abdominal pain-related functional GI disorders, which now is replaced. The functional abdominal pain syndrome is now not used anymore. It's replaced also by the functional abdominal pain not otherwise specified. And instead of having the symptoms weekly, we are using now 4 times per month, which is more precise rather than talking about weekly things. Another thing is the statement, after appropriate medical evaluation, the symptoms cannot be attributed to another medical condition, replaced the one which was before in the Rome 3 criteria, that there is no evidence of inflammatory, anatomic, metabolic, or neoplastic process that explains the subject's symptoms, which means that you don't need to do a lot of investigation. You can make the diagnosis without much of investigation in those kids. The first disorders, the functional dyspepsia, it was mentioned that only pain, functional dyspepsia as pain. It's now not just pain. It is subclassified into the postprandial distress syndrome, which includes having symptoms of fullness or satiety after eating, which is adopting the adult criteria for the functional dyspepsia, or the epigastric pain syndrome, which is having the significant pain after eating. Regarding irritable bowel syndrome, they eliminated the confusing term discomfort, which is very difficult. It's a subjective term rather than something objective, so we are talking about pain only. They defined the difference between constipation predominant IBS and functional constipation. We know that most patients with functional constipation will have abdominal pain, like 75% of them. So how can I differentiate? It is now easier. They tell you that if you have a patient with constipation and abdominal pain, you treat constipation. If the pain resolved, then this is a functional constipation. If it's not resolved, then this patient is having constipation predominant IBS. And they are adopting the adult criteria for the subtypes of IBS, the constipation predominant, diarrhea predominant, mixed, or the post-infectious. Functional abdominal pain not otherwise specified. As I said, there is no more functional abdominal pain syndrome. It is omitted now. Abdominal migraine, attacks separated by weeks, months, not returning to normal. The previous criteria was telling us that this patient should be returning to normal, which is again against the idea that those problems might coexist together. So the patient maybe is not having a normal days. He's still having pain from other causes. So the idea that the acute severe attacks will be separated by weeks or months rather than being normal, totally normal. And 2 attacks per 6 months, this is a new and stereotypical pattern that those patients having the same pattern of the severe abdominal pain each time they are coming. Defecation disorders, functional constipation, the only change was the decreasing the duration from 8 weeks after the age of 4 years into just 4 weeks. So we are now in concordance with only 4 weeks are sufficient to say that this patient is having functional constipation. And for the non-retentive fecal retention, again, it's the same. It's just 4 weeks rather than the 8 weeks previously used. Regarding functional vomiting and nausea, cyclic vomiting, again, the change that it is stereotypical back to baseline rather than normal, because again, it might coexist with other conditions and within 6 months. The functional nausea is a brand new, that those patients having symptoms at least for 2 months of bothersome nausea, not consistently associated with vomiting. And the new one also is the functional vomiting, which is again brand new, on average 1 or more episodes of vomiting per week with absence of self-induced vomiting. And in those patients, you need to exclude eating disorders or rumination because they are the major differential diagnosis in patients with recurrent vomiting. Patients with aerophagia, excessive were added to swallowing air, so excessive air rather than just swallowing air. Increasing during the day also added because logically, if they are continuously swallowing more air, you would expect that the abdominal tension will increase. And all the 3 criteria should be met for those patients to be classified as aerophagia. For the rumination syndrome, previously called the adolescent rumination syndrome. So adolescent was removed. It's now just rumination syndrome. And painless removed because most of those patients, if they have some abdominal pain, you would be like confused, is this rumination or not rumination, because we are talking about painless process. Not responding to GERD treatment also was removed because not all those patients will have treatment for GERD to start with. And rule out eating disorders were added. At least once per week was removed because most of those patients regularly they are ruminating. So there is no point that this is at least once per week. Each time they are eating, they will have rumination. Regarding treatment of those disorders, the main goal of therapy in children with FGIDs is to reestablish a normal daily life for both patient and family. The biopsychosocial model, which takes into account the physical, the psychological components of the illness, is the best way to deal with those patients. The most important part in dealing with kids with functional GI disorders is to establish a connection with the patient and family, addressing the concerns. This is very important. Tailor the workup according to the patient condition rather than try to exclude all the organic causes that might be in your list of differential. Explanation and reassurance that this is not an organic disease to start with. Medication to restore age-appropriate activities. This is just a list of what intervention we have, and I'll just shed some light on some of these treatments, not all of them. So the dietary intervention, this is a Cochrane review, maybe 2012, about the dietary interventions in patients with recurrent abdominal pain and irritable bowel syndrome. And the conclusion was there is no evidence that fiber supplementation or lactose-free diet would improve the symptoms of those patients. But a new study from Dr. Cimpitazzi at Baylor of using the FODMAP diet restriction, which is fermentable oligosaccharides, disaccharides, monosaccharides, and blooyols in patients with IBS. And the conclusion of this study that if you use this type of diet, which is really difficult to get it strict or to have this type of diet, will improve the symptoms of IBS in those kids. The idea or the theory behind that those type of sugars will be fermented, producing a lot of hydrogen, a lot of methane, and this will lead to distension, changing permeability, and inducing pain in those patients. The tricyclic antidepressants used effectively in chronic pain, it has an analgesic effect separated from the antidepressant effect. It is used in small doses in patients with functional GI disorders, specifically in the IBS patients. Need weeks to work, so this is what you need to tell the family that they should not expect that the patient will be fine after taking a couple of doses. The side effects and the therapeutic implications of those medications are not that good because they might increase sleepiness, delayed intestinal motility, and on the same time, they have some heart problems or causing tachycardia and sometimes arrhythmias. Probiotics, this is the meta-analysis from 2011 regarding the usage of Lactobacillus GG for abdominal pain-related functional disorders, and the conclusion of this meta-analysis that the use of Lactobacillus moderately increases treatment success in children with FGIDs, particularly in patients with IBS. Despite the evidence that the changes in the enteric flora by repopulation of the gut with your treatment, still there is no agreement on when or for how long and even for which type of probiotics you can use in patients with FGIDs. Cyproheptadine, widely used in children with dyspeptic symptoms, poor appetite as prophylaxis for cyclic vomiting, and even for the episodes of abdominal migraine, which is one of the antihistamines. The response rate in children with functional abdominal pain in one study was reported up to 86%, so it's somehow promising to use the cyproheptadine. Montelukast, used based on the finding of duodenal eosinophilia in children with functional dyspepsia, and 2 small studies in children were reporting a significant clinical benefit of the Montelukast. What's the burden of functional GI disorders? A recent meta-analysis reporting that the estimated prevalence of worldwide functional abdominal pain disorders around 13.5%. South America, Asia, having higher rates compared to Europe or North America, while functional constipation affecting up to 30% of children at the school age. What about Jordan? A couple of days ago, it was the 4th anniversary of translating the Rome criteria into the Arabic language. And since the translation was available, it opened the door for us to estimate the problem in our society. So the project was to have estimating the prevalence of functional gastrointestinal disorders in Jordanian children. And this project is part of the study for the Mediterranean area and Europe, and supported by a network grant from the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition. So our method was that has The prevalence of functional GI disorder has been assessed using Arabic version of the questionnaires on the pediatric GI symptoms. The parent report form has been used for children between the age of 4 and 10, which is group 1, while the self-report form was being used for the kids between the age of 11 and 18. And children and adolescents have been enrolled in schools distributed throughout the national territory. In group 1, which is between the age of 4 and 10, a total of 773 subjects, almost 50-50 males and females, with an average median age of 7.9 years completed our study. A total of 192 subjects, which is almost 25%, met the criteria for FGID, and defecation disorder were the most common group of FGIDs. While functional constipation was diagnosed in 12.2%, abdominal pain predominant FGIDs were seen in 7%, while abdominal migraine and IBS were the most common in those children. In group B, between the age of 11 and 18, a total of 815 children recruited, males 46%, with the median age was 14.9 years. A total of 322, which is almost 40%, met criteria for FGID. And again, abdominal pain predominant at this age were the most common, affecting 18% of the children, followed by the defecation disorders. This is just a table to show you the prevalence of each of the categories that we were talking about. And you can see that in the age group of 4 to 10, that functional constipation, 12.2% in those patients. This is for the older age group between 10 and 18, and you can see that abdominal migraine and irritable bowel syndrome were, and functional dyspepsia contribute almost to 20% of the functional GI disorders. This is just to show you some simple comparison between Jordan and other countries, developing countries like Ecuador, Sri Lanka, Nigeria, and Jordan. The numbers in the Ecuador study is much lower than our numbers. The problem with the Sri Lankan and Nigerian studies, they were talking mainly about the abdominal pain related disorders, so they are not reporting the other disorders. So almost 40%, this is for the age group between 11 and 18. I assure you that we have the numbers from Italy, which is around the same number. 40% of their children met the criteria for one of the functional GI disorders. So this problem is in the rise worldwide, and we need to put a lot of strategies to deal with such problems. In conclusion, functional constipation is the most common functional GI disorder in Jordanian children between the age of 4 and 10, and abdominal pain predominant functional gastrointestinal disorder are the most common, followed by functional constipation in Jordanian children between the age of 10 and 18. And thank you.